Earthquake in Turkey. This video was created for the surgeons who stand up for the lives of the victims. Lower extremity fasciotomy technique. This video has been produced from an article source. Thanks for the author, Mark W. Bowyer. Citation: Bowyer, M.W. Lower extremity fasciotomy, indications and technique. Current trauma reports. 2015. 1.35-44, 2015. The lateral incision of the lower leg. The lateral incision, figure, is made 1 finger in front of the fibula and should in general extend from 3 finger breadths below the head of the fibula down to 3 finger breadths above the lateral malleolus. The exact length of the skin incision will depend on the clinical setting, and care must be taken to make sure that it is long enough such that the skin does not serve as a constricting band. The skin and subcutaneous tissue are incised to expose the fascia encasing the lateral and anterior compartments. Care should be taken to avoid the lesser saphenous vein and perineal nerve when making these skin incisions. Once the skin flap is raised, the intermuscular septum is sought and identified. This is the structure divides the anterior and lateral compartments. In the swollen or injured extremity, it may be difficult to find the intermuscular septum. In these circumstances, the septum can often be found by following the perforating vessels down to it. Figure. Classically, the fascia of the lower leg is opened using an H-shaped incision. Figure. This will be accomplished by making the crosspiece of the H, using a scalpel which will expose both compartments and the septum. The legs of the H are made with curved scissors using just the tips, which are turned away from the septum to avoid injury to the perineal nerve. Figure. It is important to identify the intermuscular septum and open the fascia at least 1 cm from it on either side, because the terminal branch of the deep perineal nerve perforates the septum in the distal 1/3 of the lower leg, and this could be cut if care is not taken. The anterior and lateral compartments are then fasciotomized 1 cm in front and behind the intermuscular septum. The fascia should be opened by pushing the partially opened scissor tips in both directions on either side of the septum, opening the fascia from the head of the fibula down to the lateral malleolus in a line that is 1 to 2 cm from the septum. Inspection of the septum and identification of the deep perineal nerve and/or the anterior tibial vessels confirm the entry into the anterior compartment. The skin incision should be closely inspected and extended as need to ensure that the ends do not serve as a point of constriction. As previously stated, the anterior compartment is the one most commonly missed during lower extremity fasciotomy. One of the reasons for missing the anterior compartment stems from making the incision too far posteriorly, either directly over or behind the fibula. When the incision is made in this manner, the septum between the lateral and the superficial compartment may be directly below the incision and is erroneously identified as the septum between the anterior and lateral compartments. Figure. When the lateral incision is made 1 finger in front of the fibula, the intramuscular septum between the anterior and lateral compartments is found directly below the incision, making successful decompression likely. Figure. The medial incision of the lower leg. The medial incision is made 1 finger breadth below the palpable medial edge of the tibia. Figure. When making this incision is important to both identify and preserve the greater saphenous vein, as well ligate any perforators to it, as these can bleed profusely. After dividing the skin and subcutaneous tissues, the fascia overlying the superficial posterior compartment, which contains the soleus and gastrocnemius muscle, is exposed. The fascia should be opened with partially opened scissors from the tibial tuberosity to the medial malleolus to effectively decompress this compartment. The key to entering the deep posterior compartment is the soleus muscle. The soleus muscle attaches to the medial edge of the tibia, and dissecting these fibers, the soleus bridge, completely free from and exposing the underside of the tibia, ensures entry into the deep posterior compartment. Figure. Identification of the posterior tibial neurovascular bundle confirms that the compartment has been entered. As previously discussed, the deep posterior compartment can also be missed, and thorough understanding of the anatomy is the key to ensuring that this does not happen. One potential way to miss the deep posterior compartment is to get into the plane between the gastrocnemius and soleus muscle and believe that the compartment has been released. Figure. Proper decompression of the deep posterior compartment requires that the soleus fibers be separated from their attachment on the underside of the tibia. Figures. Wound care. The muscle in each compartment should be assessed for viability. Viable muscle is pink, contracts when stimulated, and bleeds when cut. Dead muscle should be debrided back to healthy viable tissue when necessary. Generally, fasciotomy wounds are not closed at the time of the initial procedure. These wounds are often large and tissue swelling, skin retraction, or tissue loss make these wounds impossible to close at the initial setting, and closure would also defeat pressure decreases obtained by fasciotomy. Wound management focuses on swelling control, allowing recovery of injured tissues, and minimizing skin retraction. Patients are generally returned to the operating room every 24 to 72 hours for dressing changes, re-evaluation of muscle viability, and gradual closure of the wound. If the wounds cannot be primarily closed within 7 to 10 days, split-thickness skin grafts. Thanks for watching. Please subscribe my channel. Orthopedics Trauma in YouTube. Subscribe.